Welcome, everybody. So I am here to introduce Dr. McAdon, who is clinical professor of medicine at Harvard Medical School and director of the National LGBT Health Education Center at the Fenway Institute, which is a division of Fenway Health in Boston, Massachusetts. Dr. McAdon is the lead editor of the Fenway Guide to Lesbian, Gay, Bisexual, and Transgender Health. If you haven't read that, it's really, really a great book. I actually own it. Had I known I was going to do this today, I would have brought it in for you to sign. So I'm going to pass it on to Dr. McAdon.
Thanks, David, and thanks everybody for coming. I know that there's more than you can learn in a day or two at these conferences, but I do think that LGBT issues in public housing are very important because at least from, I know a number of colleagues who work in various public housing programs in the Boston area, they feel that there needs to be a greater understanding of LGBT issues, and so we're happy to be able to provide this. I work at the Fenway Institute as the director of the National LGBT Health Education Center, which is a national cooperative agreement with HRSA, and so we're pleased to be invited here today to participate in this conference. Now, first I have to start by giving you a quiz. Now, yesterday the quiz didn't work, but we'll see if it does today. How would you rate your knowledge on ways to communicate with LGBT patients about issues related to their sexual orientation and gender identity? And here, you might substitute the word clients because some of the people in public housing aren't necessarily patients, but are clients. But the issue is, how do you relate to people on issues related to sexual orientation and gender identity? And we've had 2 people respond so far. Polling's still open, so we'll give you another 5 seconds. There's a little clicker in front of you. 7 responses, 8 responses. Wow. Excellent. So 25% of people are great at doing this, and then about 40% are good or fair at doing this. And no one feels like they really need a remedial course, so that's pretty good. So now the next question is, how do you rate your knowledge on strategies for sensitively collecting and documenting sexual orientation and gender identity information among the people in public housing? Excellent, good, fair, or poor? Okay, so we're a bit mixed here. And this is actually interesting, so that a number of people do it, and this is sort of consistent with, we did a survey of community health centers when we started our national cooperative agreement, and about 30-some% said they had a system for collecting data on sexual orientation and gender identity, which, to be honest, surprised me that the number was that high. But clearly there's work to be done if we're going to really understand who we're taking care of, and particularly if you think about LGBT residents may have special needs or have issues that they want to talk to you about but don't necessarily want to make public, then collecting this information is going to be important, and 70% we can think about ways that we can be more effective. And then how would you rate your knowledge regarding well, this is an electronic health record, so this probably isn't relevant for all of you, but it may be relevant for some. So to obtain information on sexual orientation and gender identity in electronic health records. So we'll just look at this. So again, no one is doing it perfectly, but some people are starting to do it, and there's some work to be done in terms of electronic health records. But actually, let me just get a sense of the group. How many of you actually work in a place that actually has a health center that has an electronic health record? So almost everybody, but some don't. And so I think that it's a mixture, but I think clearly, as you're going to see, I'm going to talk about developing a system to obtain this information. And then the question is where you put it. And in a healthcare facility, it would be the electronic health record, but there may be alternatives in other kinds of facilities or organizations, and it'll be a good thing for us to talk about. So our learning objectives are to understand LGBT health disparities and social and structural factors that influence them. Describe the cross-sections of LGBT, identity, poverty, and public housing. How many have heard the term intersectionality? So intersectionality is a term that's kind of increasingly being used to really talk about populations that have multiple different social issues, identities, cultural backgrounds, all kind of colliding into one person, and how people sort those out can be very important in terms of either whether they get kind of overwhelmed and depressed or stay resilient. And I think that's a term that the Institute of Medicine talks about in the LGBT health report that I'm going to mention, but it's an important term that's being increasingly used. Identify strategies for sensitively collecting and documenting this information. Recognize initiatives to obtain information about sexual orientation and gender identity, and describe ways to communicate with LGBT patients or clients about issues related to their sexual orientation and gender identity. So why LGBT health? Why did HRSA decide that LGBT health was something that should be a national cooperative agreement, or the topic of a national cooperative agreement, to work with health centers across the country? And one of the reasons is because of the healthcare disparities that have been described among LGBT people, but it's also important to understand the origin of those healthcare disparities are not things that are too complicated, but they are difficult to deal with. So stigma and discrimination, bias in healthcare, social determinants of health are all things that have led to the kind of disparities that we now understand. When we talk about a long history of bias in healthcare, it's important to note that physicians have a long tradition of not really discussing sexual orientation or gender identity, and they're often uncomfortable providing care to gay or lesbian patients or transgender patients. A lot of patients don't want to have a gay or lesbian doctor, which creates another dynamic. Medical students still report that they hear comments when they're making rounds in the hospital with attending physicians or with residents about LGBT people, and that makes them uncomfortable as people who are getting trained. So I think it kind of has a double-edged problem. And transgender people have experiences kind of with frank refusal to get care from certain providers, and often that's because they don't really know anything about transgender health. And often they feel like they have to teach their doctors what it is that they need when they go get care. I was sort of intrigued when I visited a health center actually run by a Catholic organization in New Orleans. And I went in and I was kind of meeting the physicians who were there, and I saw that one of them had this group of this series of monographs that were put out by the University of British Columbia, Coastal Health Services, which runs healthcare in British Columbia, on transgender health. And I said, well, how did you happen to have those here? And he said, well, a few weeks ago, I had a patient come in and say that he was transgender, and I didn't know anything about it. So I felt like it was important for me to kind of have the person come back, but in the meantime learn what I could to take care of him. And I think he did exactly what a good primary care clinician needs to do, because a lot of the things are not complex, but you still need to have some framework for understanding what you need to do to provide the best in care, and this guy did it. I mean, it was really quite nice to see this as an example of what you can do in a primary care setting. The resources are out there, but we have to have the willingness and the desire to go ahead and get them. LGBT people have also had developed a number of disparities related to a long history of stigma and discrimination, and sometimes it's directed at them as individuals, and sometimes it's just sort of societal. So for example, here we have a picture of Tyler Trinetti, who's been in the news recently and who 2 years ago was observed by his roommate to be having sex with another man. That person recently went on trial and was found guilty of a health crime, but unfortunately, Tyler at the time that happened, committed suicide by jumping off the George Washington Bridge. The woman to the right here is a transgender woman who reported abuse by the police in her own community and then 6 weeks later was found dead. All of these things, the bullying down here, the sort of international lack of acceptance of gay people and often resulting in hanging for violating sodomy laws, can have an impact on people no matter where they are. And whenever we read about these things, we can kind of feel a little bit of ourselves being sort of picked away in terms of our ability to be resilient. And we have to be thinking about what we can do to help people in order to prevent the impact of stigma and discrimination. The social determinants of health are clearly a critical issue. You know that more than anybody. There's a lot of LGBT people in homeless shelters and public housing, and they're there because they have lower socioeconomic status. They often can't get jobs. They're thrown out of their homes by their parents. So there's a multitude of reasons. One of them is also that there aren't physicians who are trained to take care of them, or nurses who are trained to take care of these kids. And so therefore, one of the social determinants of health is lack of access to health care that's appropriate for them to be seen at. And so, we see these as all kind of origins of or etiologies of social determinants of health, of disparities in health care. There were these two books that were written in the past year. I've alluded to the one on the left. The one on the right, you probably all know for many years, which is the Surgeon General's every 10-year report. This was the first time, Healthy People 2020 was the first time the Surgeon General actually laid out LGBT goals and based on the disparities that were found. The book on the left was published last spring by the Institute of Medicine. And the Institute of Medicine, for those of you who don't know, is a very sort of august group of mostly physicians, but health professionals, nurses, physicians, who are chosen to kind of develop health policy in areas of difficulty. So they did a lot of the work on quality, that book, Across the Quality Chasm, that anyone who runs a health center probably has read 20 times, because it's become like one of the Bibles of what we need to learn about in terms of improving quality of care. They've done a lot of books on HIV, and then now they've done this one on LGBT health, with a focus on understanding disparities, but also identifying issues that the National Institutes of Health, this was commissioned by the National Institutes of Health, but identifying research that needs to be done to better understand the needs of LGBT people. So this is a little summary of the Institute of Medicine report, and the main thing was they conducted a review and prepared a report assessing the state of science on the health status of LGBT people. They showed that disparities exist across the life cycle, and from Healthy People 2020, we learned that these disparities were things like among youth, 2 to 3 times more likely to attempt suicide, more likely to be homeless. LGBT people have the highest rates of tobacco, alcohol, and drug use. Gay men are at higher risk of HIV and STDs, especially in communities of color. So that just this year, the CDC came out with data from, the most recent data they came out with was from 2009, but showed that 64% of new cases of HIV were among men who have sex with men or transgender women. And there was a shockingly almost 50% increase in the number of new cases among young black MSM who may or may not identify as gay, but do have sex with men. And I think a big question for lots of organizations is how to find those people who are at risk for HIV and what to do to really help them. Lesbians are less likely to get preventive services for cancer. Lesbians and bisexual females were more likely to be overweight or obese. Transgender individuals, again, have a high prevalence of HIV, victimization, mental health issues, and suicide. They're less likely to have health insurance and get access to care of any sort than heterosexual or lesbian, gay, or bisexual individuals. And again, yesterday we had a conference here on aging, but elderly LGBT individuals face additional barriers to health because of isolation, lack of social services, and having culturally competent providers who, again, can find out more about them, to find out, why they may be so isolated, which often may be related to their sexual orientation or gender identity, and then help them deal with that. So here, in terms of public housing, and that's actually in the upper left, is a photograph of a older housing program in Boston. But we have the intersection of poverty, housing, race, and LGBT people, and that's really kind of what we're thinking about today. A lot of people sort of come to a talk on LGBT health and think about the stereotypes we see on TV and programs like Modern Family on the left, or the L Word on the right, or Will and Grace a few years ago. But, we didn't really have these kinds of kind of shows that were so public in the past. But what we don't see is the reality of what it means to be LGBT, because many LGBT people live in poverty. 24% of lesbian, bisexual women live below the federal poverty line, compared to 19% of heterosexual women. 15% of gay and bisexual men live below the federal poverty line versus 13% of heterosexual men. African American same-sex couples have a poverty rate of 21% versus 9% in traditional African American married couples. So, and there's no data on transgender people, but small studies do suggest very high poverty rates, and as I said in the other slide, often don't have health insurance. Now, hopefully that is going to change sometime in the next year or so, but at this point that's clearly an issue in terms of health care. So the reality is that LGBT people are more likely to be found in homeless shelters, more likely to be found in public housing, and sometimes, often, they're invisible unless we do something to find out who they are. The reasons for increased risk of poverty are homelessness, lack of marriage benefits for most. Few states offer employment discrimination protection or recourse. Women generally earn lower than men on average. Elderly LGBT people are less likely to have family members or partners or other potential safety nets that they can draw on. And they're all less likely to receive family income support. And then there's the issue of housing discrimination. Hopefully this has come to an end. That HUD, Equal Access to Housing Law in 2012, requires that HUD-assisted housing, or housing whose financing is insured by HUD, make housing available without regard to sexual orientation or gender identity. But that wasn't always the case. And this act also makes it clear that the term family includes LGBT individuals and couples as eligible beneficiaries of HUD's public housing and voucher programs, programs that now collectively serve about 5.5 million people. So again, I think that, in the last few years, this was true yesterday when we talked about aging people, and it's also true about, homeless shelters and public housing. There have been a lot of executive orders that can make a difference for LGBT people. Again, we have to make people comfortable that it's okay to talk about the fact that they are LGBT so that they can actually take advantage of these, because too many people have felt like they wanted to stay away from certain places because they weren't going to get the benefits that they thought they needed, and now we need to kind of re-educate people a bit. So Secretary Donovan said you cannot use taxpayers' dollars to prevent Americans from choosing where they want to live based on the basis of sexual orientation or gender identity, ensuring that HUD's housing programs are open not to some, not to most, but to all. And so I think that's a welcome message, and that's something that we can begin incorporating it into our programming. Again, there's no specific data on LGBT people in public housing, and I'd be interested at the end, or anytime anyone wants to comment on any kind of anecdotes you might have about, experiences with LGBT people. But all people living in public housing face complex social, economic, physical stressors and general safety concerns which contribute to multiple health problems. So again, bullying in public housing is no different than bullying in schools. And, we know it goes on, but, people haven't really been focused on looking at what to do about it or how to change that. And so those kinds of programs are the kinds of things that need to be thought about as people are going to be more open about being LGBT living in public housing. People who are LGBT can face additional stressors that impact health. For example, as I just mentioned, coming out can lead to isolation and rejection, verbal and physical abuse or bullying. Hiding sexual and gender identity can also lead to mental distress, isolation, and self-hatred. Internalized homophobia becomes a sort of fact of life and affects people's well-being. So I do think that, the best world is one where people can feel comfortable about themselves, and hopefully that as policies change and as we begin to talk more about these issues in venues like public housing, that we can begin to make a difference and have people feel like they can be comfortable being themselves. But there is a dual stigma if both racial minority and sexual minorities are not dealt with. It was interesting that I talked with a medical student the other day who said that at Harvard Medical School he felt much more comfortable being a black medical student than he did being a gay medical student, because the black students had much more support from the medical school than the gay students do. So that was a sort of, felt to me like a shame that he has dealt with a lot of issues, but the gay part of him is the one that still feels the least, where he feels the least comfortable being open about himself. And people often feel excluded from both the gay community as well as their community networks. And these conditions can make it more difficult to access healthcare testing, social supports, and other resources. As I said before, we have to create a world where people feel comfortable coming forward, or they're not going to get the health care that they need. Now, just quickly to go through LGBT demographics and concepts, I just wanted to highlight again that LGBT is not a homogeneous group of people. That LGBT are all different populations. They are all very diverse populations, and each one of them has a number of sort of cultural connections and identities that may be very different from another. And we have to recognize that we're not dealing with a stereotypical group. The Institute of Medicine, again, highlighted the fact that there's a diversity of expression in LGBT communities in general, and we have to recognize that where we work. Understanding sexual orientation is more than just, is someone gay or lesbian? It's a combination of understanding one's identity, their behavior, and their attraction. And in fact, a study in New York City in 2006 showed that 9.4% of over 4,000 men who were interviewed in the study, and of those who identified as straight in the study, 9.4% had had sex with a man in the prior year. This was in the West Village in New York City. So it's not like we're talking about Kansas, as they say. But these men were more likely to belong to minority racial and ethnic groups, be of lower socioeconomic status, be foreign-born, exactly the kind of people who are probably going to be in public housing or homeless shelters. But they also didn't use condoms, so also at higher risk for HIV. So that when we begin to think about why do young black MSM, why are they at higher risk for HIV, and why are they getting HIV in higher rates, the answer may be partly because they're not willing to be kind of clear about their behavior. They don't want to talk about their identity, and they're hard to find, and they're hard, and yet we have to think about how we do that. Lesbians also have sex with men in a number of studies, and so we can't make assumptions about people just by their identity or their sexual orientation. People often hide or reject their gay or bisexual identity, and we've really talked about this, but our goal is to help people be themselves. When we look at the map of the United States, we see that same-sex families are found across the country. The darker areas show where there's a higher prevalence, over 7.7 same-sex families per thousand. So that obviously on the East Coast and the West Coast you see more darker areas, but there are same-sex families found in the census in 99% of counties. So no one can really have a health center or a public housing unit almost anywhere in the country and say, oh, we don't have LGBT people here, because they may just not be talking about who they are, but they're there. And we have to help them feel comfortable being themselves. These maps kind of hone in on Hispanic and black same-sex couples, and again show you that they live in areas that are traditionally where Hispanic and black families live. And so again, health centers in these areas have to recognize that a number of people who they provide care for or housing for are LGBT. And think about that when they develop programs, they develop questionnaires, and do it in a sensitive way. In terms of the overall demographics in the United States, it's felt that about 1.7 to 5.6% of people are lesbian, gay, or bisexual, but more people have had same-sex contact at some point, and even more have had same-sex attraction, 7.5 to 11%. And this is the most recent data that we have. Transgender is a more complicated term to understand. It changes a bit, but transgender people are generally those who persistently identify and express their gender as the opposite of their birth sex. Now, one of the things that people think of is, oh, these people get hormonal therapy and surgery, and they transition to the person they want to be. But that's not always the case. Sometimes people don't get medical or surgical treatment, and they still have the same feelings, but they don't get treated in that way. And so it's important to recognize that not everybody gets medical treatment, and it's not just because they don't have access to it. Some people just choose not to. Some people define themselves not as transgender, but still as a gender outside of either the construct of male or female. That is to say, they sort of reject the binary, kind of traditional binary concept of male or female only, and think of themselves as having no gender or being androgynous and having elements of multiple genders. And they might call themselves bigender or genderqueer. And this is particularly true, and I don't know if many of you, deal with adolescents, but this is particularly true in adolescents. I suspect you probably see this at the door. And then a lot of people kind of are willing to accept their gender, but occasionally like dressing up as someone of an opposite gender, and those people dress in clothes and are called cross-dressers. So again, gender expression can vary a lot. Gender identity can vary a lot, but we do need to begin to understand these terms and talk to people about it if we're going to recognize that they are living in our various programs, and they're getting care that they need. In order to get appropriate care, you really do have to know what someone's basic anatomy is and provide care appropriately. So what can we do to overcome the barriers to actually making sure that these people get the services they need, the care they need, and are able to live fulfilling lives? So I just had some quick questions to ask you, and because I think that invisibility in healthcare is very common in this group. But how often has a clinician ever asked anyone in this room about their sexual orientation when you went for a regular visit? So one person in the whole room, that's actually very usual. I mean, it's not uncommon to actually talk to a group of 200 people and have one or two people say their doctor ever talked to them about sexual orientation. What about gender identity? So you can see that you could be transgender or gay or lesbian or bisexual, go see a clinician, come back home and never have had that person ask you one thing about it, which is probably, for many people who are LGBT or T, a very important part of their life. It may be the defining part of their life for many people. It may not be. But nevertheless, it's still an important part. And I once wrote an article about my sort of coming out and going to the doctor when I was 40 because I thought, well, I should have a physical exam. And at that point in time, I wanted the doctor to tell me to go get HIV tested. And I made up my mind in advance that I was going to say I'm gay. I went in. This was at the Mass General, so it was like in Boston. It was like going to, like it wasn't my hospital, but I was going to a really good doctor. I told him I was gay. He never said another word about it, not one thing. Didn't mention anything about HIV. Didn't talk about reducing risk of HIV. Didn't talk about getting HIV tested. Never ever once talked about the word again. So as a result, I mean, how do you think I felt? I mean, I felt like, well, this was a bummer, getting all ready to sort of see a new doctor, and I was 40, and I thought I needed to have all these things done and everything. I never went to him again, and then it took me probably another 5 or 6 years to find another doctor who turns out to be great, and I continued to go see him. But I think that experiences like that can be damaging for people. And I'm a physician, so I sort of know what to do. But for people who aren't, it's a lot more difficult. And I think we have to think about what meanings we give. So how well do you know the people coming to your health center, and how do you find out? So if people come in the door, how do you know if they're new patients or they may be new lesbian, gay, or transgender patients? What systems do you have in place to sort of sort out that kind of information? And is one of the reasons you may not have systems in place the way people feel about not being comfortable dealing with the information they're getting, or that you're not sure exactly how it's going to fit into the kind of social structure that is currently in place where you work? So we've actually, at Fenway, we've just developed these 2 policy briefs called Why Gather Data on Sexual Orientation and Gender Identity in Clinical Settings, and then How to Do It. And I do think that these are available for free on the Fenway Institute website. But I think that whether you're a health center or a public housing program or a homeless shelter, kind of thinking through these issues and how they may be relevant for your organization are really going to be critical if we're going to provide, under the Affordable Care Act, population health. Because if we don't know who the population is we take care of, we're not going to be able to do a good job creating a consistent group of enabling services that are going to make sure that people get the care and services that they need. So I think everybody in the room has to be thinking about this. It increases our ability to screen, detect, and prevent conditions more common in LGBT people. It helps develop a better understanding of people's lives. It also allows for a comparison so that we can make sure that people are getting what they need, and people may feel safer discussing their health and risk behaviors, not only once they've disclosed this information, but even once they've been asked this information. It may take 3 or 4 visits until they actually come and talk to you about it, but at least they know that you're willing to hear the answer. And a lot of people go to the doctor or the nurse or the social worker and don't feel like that's the case. So one of the things that we're trying to suggest is that, now this is really oriented towards like a health system, but that people could input data from home in a kind of patient portal that then goes to the health center, or they could input data around sexual orientation or gender identity at the point of registration, and that the provider could actually use the information they've already provided to talk to them and answer questions. But if they haven't provided that information, the provider can actually ask that information and ultimately enter it into the electronic health record where it can be kept and where other clinicians can have access to it. Now, we do want to assure people about confidentiality, but the electronic health record can clearly mean a big difference. This is the way we ask these questions at Fenway, at least with respect to sexual orientation. So this is, this is a screenshot of our demographics page, or at least part of it. And we sort of say, do you think of yourself as lesbian, gay, or homosexual, straight or heterosexual, bisexual? But then we'll allow people to express something, you know, that they may think of themselves in some other way. And also that they don't know, that they may be questioning this and want to talk to someone about it. So, you know, that's sort of something that we're now testing. We based this on focus groups with patients. We're doing the same with transgender people now, but this is what the Center of Excellence for Transgender Health at UCSF recommends. They recommend that you ask, what sex were you assigned at birth, what your current gender identity is, and we kind of go through a list of things that I've talked about, but also what pronouns do you prefer? Do you prefer being called he or she if someone's referring to you in the waiting room? What name do you prefer being called? You may be registered as Lou on your medical insurance, or Louis, but yet you may have decided that you now want to be called Louise. And you might dress like Louise, and so you don't want someone in the waiting area calling you Lou. So, you know, clinics now often offer people, not often, clinics are beginning to offer people an opportunity to say, what name and pronoun do you want to be called? So that people can feel comfortable doing the right thing. And if you do kind of mess up, you can always apologize to somebody, but nevertheless, there are ways to think this through. And then obviously clinicians need better training in talking to patients. That's not one of the strong suits of, I know nursing schools or medical schools and don't do a great job at teaching people how to talk about sex, how to talk about taking a sexual history. This is a study of proportion of patients, physicians discussing topics, various topics with HIV-infected patients. And it's interesting that 84% talk to patients about how they use their antiretroviral therapy, their ART, but only 14 or 16% talked about more intimate issues like condom use or HIV transmission or risk reduction, suggesting that maybe that's a little bit more complicated and people don't feel as good about getting into it. It also led the Institute of Medicine to say in a more recent report that it may require a greater intimacy to discuss sex than to engage in it. And I think that it does highlight the fact that we, as a society, tend not to talk about these things. And even though clinicians talk to patients about all kinds of things, and people are pretty willing to be forthcoming, the doctors and nurses and social workers don't feel comfortable when they get into certain areas of more intimate issues. But I think that the core of the cross-cultural interview is that we can really ask people almost anything as long as we do it with appropriate curiosity. That is to say, you're curious about something that you have a reason to know about as opposed to just kind of wanting to ask. You're respectful and you're empathic, and that we can actually talk to people about things that they may not talk to people about generally. But if we ask them these questions, they're actually going to trust us more in the long run because they're going to feel like we're open to hearing from them. So the core history for LGBT people is pretty much the same as it is for all patients. It's important that we use inclusive and neutral language. So we wouldn't say, you wouldn't want to say, are you married? Or do you have a boyfriend or girlfriend? But you might say, do you have a partner, or are you in a relationship, and what do you call your partner? They're subtle differences, but they're things that can make a difference to people who traditionally haven't really wanted to come forward and talk to people, and these are ways of getting people to feel more comfortable. We have to ensure confidentiality, explain that why we're asking these questions is important to people's health, and be open to the fact that terminology is evolving, as I mentioned before. In terms of the sexual history, we have to make sure that people know it's routine and it's something that you're asking all of your patients. And then talk about behavior and risk, talk about sexual health, and talk about comfort with sexuality. So that we're not just talking about risk, we're talking about really people's satisfaction with their sexuality. And these things can make a difference. Now, I know that you're not all working in health centers, but at some point, someone has to be concerned about the health of the people who are living in your housing. And often I know there are health centers that are attached to public housing units. It's important that this information be gathered if we're going to provide appropriate care. And then it's important that we repeat this, because behavior and identity can change over time, and that remember that identity and behavior don't always match. So it's not overly complex, but it is something that we're not taught and we don't do, and we may not do because we feel uncomfortable. But the more we practice doing it, the more we do it on a routine basis, the easier it's going to be to do this routinely. And then ultimately, it's also important to discuss gender identity. Now, some people feel that transgender people or people who have gender issues might prefer to provide that information in advance of a visit, but if not, providers can ask if patients have questions about gender identity and follow up as appropriate. In addition to the sort of clinical things, we have to think about how to create better environments for caring and working. And that's actually a picture of a health center in New York that does a lot of LGBT health care, Cal and Lord. But I think these are fairly typical kind of health center scenes. I'm sure all of you know that the Joint Commission has now put out this field guide, which is directed at hospitals, but really looks at how to create an environment that's appropriate for LGBT people coming and getting care. And at least our hope is that these will ultimately become part of the official Joint Commission survey. But things like, do you know if LGBT people feel welcome? Has anyone surveyed patients as they come into the health center? Do you know if employees feel safe and accepted? Do people feel comfortable being themselves? Are clinicians and staff taught about LGBT health needs? Do people at the front desk understand why you gather this information? Do they understand the issues about using the right pronouns with people? Because this is an issue that you have to think about from the minute someone comes for health care until they actually leave the health center. And it may be even a wider network depending on where you work and what you do. But you have to make sure that everybody sort of understands the issues that people may have. Is the board of directors involved? Are they concerned about this? And then is there an organizational structure that can adjudicate things if someone says, oh, so-and-so really made a nasty comment about a gay person when they were seeing patients the other day, and it made a number of the staff people feel uncomfortable. Is there some way to deal with that? Is there an adjudication process? And then when we think about the patient environment, is there a non-discrimination policy? Do you have images in the health centers or in public housing that reflect LGBT lives? Is there a rainbow flag at Pride Week? Do you have educational brochures on LGBT health topics, on HIV prevention? And is there a unisex bathroom for a transgender person to feel comfortable so they don't have to negotiate the sort of male-female divide and end up feeling uncomfortable when they have to just do a simple task like go to the bathroom? So these are things that kind of we know make a difference and that I think easily can be developed so that you can provide a more inclusive environment for people. But if we don't think about it, it won't be done. At Fenway, we have also created certain groups for people like, as I said, young black men often feel uncomfortable in terms of the community or the separate worlds they live in. So we have support groups for gay and bisexual black men to talk about their experience in the black community and in the LGBT community, and how do they find or create a community where all of their identities are accepted. So again, this is just one example of the kind of program that could be developed for people so that they feel more comfortable and more willing to be forthright about themselves. I think in ending, I just wanted to mention that we're all, this is actually the Affordable Care Act, but we're all in the process of thinking about how our health centers become patient-centered medical homes. And as I said before, a lot of that depends on our knowing who we're taking care of. So that if you look at the core standards for patient-centered medical homes, we have to be able to identify and manage patient populations. Well, if you don't know if you're taking care of LGBT people, you can't really manage LGBT issues effectively. So it requires that you get this kind of information up front. And then in terms of planning and managing care, that's also kind of critical to know, who you're taking care of. So that in addition to the elements of the population, if you have a population of transgender people, you have to think about what kind of system of care you need to be clinically effective and cost effective in taking care of them. If you have a group of people who have significant behavioral health problems, like you're taking care of a lot of LGBT adolescents, but you didn't know that, you'd have to think about, well, how do we manage that without spending, having our budget go through the roof, especially in the sort of patient-centered medical home era. And HIV prevention and care is another area where if you do it effectively, you can actually make a big difference, particularly in preventing cases of HIV, which are going to be very expensive. But we have to know, who's at risk and what we can do to both care for them when they're in the health center, but also care for them or provide enabling services to make sure that they're actually getting back to their visits, that they understand the medications they're taking, and think about using sort of peer navigation programs or other programs that are outside the health center that may be in a drop-in center or maybe, in the social service unit at a public housing program, but end up really trying to work together as part of a healthcare system to make sure that people get appropriate care. So I just wanted to end by saying, as I said before, this is the National LGBT Health Education Center is part of the Fenway Institute. We have this cooperative agreement. We love working with health centers to help them think through the issues that I've raised. We also work with academic medical centers on the same kinds of issues, and anyone who's interested, feel free to contact us. At this point, we have 15 minutes. So it would be, I would be interested, I skipped a case that we had, but I'd be interested to hear from you about what your thoughts are about issues that you found challenging in either thinking through what you might need to do to implement some of these things, or issues that have come up in your housing programs or associated health centers already, and begin to talk about it a little bit.
Well, I have a question. Cynthia Davis from the Floating Hospital. When I go on outreach to different type of people, out there in public housing, we have listed all our services, primary health care service. Is there a certain service that we should use or say for LGBT?
Is there a certain what?
Services that LGBT people are looking forward to have besides just health care services?
My sense is that obviously things like HIV testing is something that people or STD testing are things that people are, should be concerned about, but they may not know it. And so I think that I'm not so sure it's so much the specific services, but that they be organized in a way that are, that people all understand both the importance of sort of continuity of care and that you're all working together as part of a system. I guess, as we go through this transition from, hospital, like I've worked most of my life at a hospital, not at a health center, although Fenway's right down the street from the hospital I worked, and I work there all the time now. But like 20 years ago, more than 20 years ago, I hate to say, in 1985, people used to come to the health center, and if they had HIV and needed to be hospitalized, they would send them to the emergency unit. So the doctors from Fenway didn't come to the hospital, didn't see their patients, but then they would complain because the patients got lost to follow-up in the hospital, and they'd end up being taken care of by people who work in the hospital. And so as a result, and having seen that, I actually worked with Fenway and with the hospital administration, and we got the doctors at Fenway to have staff privileges at the hospital. And at that point in time, I mean, it may seem like an everyday thing now, but at that point in time, health center doctors didn't get academic teaching appointments. But we got them appointments at the hospital, and then the expectation was that they would follow their patients. So they didn't just send them to the emergency unit. They sent them there, they went there to see them, they saw them if they were admitted to the hospital, and if they were discharged, they were involved in making the plan to make sure they got the services in the community they needed and got back to primary care at the health center. And I think the same kinds of things are happening now, only it's more important that this network of enabling services and the primary care providers and the hospitals work together so that it's really seamless and you can really share information that's appropriate and make sure that people can make it through this system. And it doesn't really, it doesn't matter if they're LGBT or if they're, kind of homeless people who just happen to kind of fall out of the system. You really want to make sure that you're creating a system of care. So I actually gave a talk in Boston a year and a half ago to an elder services group on the North Shore of the city, which is up sort of between Boston and New Hampshire. And I listed all of the elder services groups that worked in that community. And I had a list of like 15 services. And they didn't know each other. I mean, but they all did slightly different things, for elder patients. And I said that there's no way that we can be efficient. There's no way that I, as a primary care doctor, can be efficient in managing my patients if there's not some sort of connectivity among all these different groups. Because I can't be sending patients to one group for one thing and another group for another and feel like they're not talking to each other. And I think that's really the core of successful care for any population, is that we need to create systems of care that go outside the walls of the health center, outside the walls of the hospital, and include the kind of services that you provide, in your public housing programs, in elder services programs, whether they're daycare programs or overnight programs, in homeless shelters. And we really have to create systems of care. And the real goal of patient-centered care is to have that kind of system in place. So I don't know if that kind of goes beyond your immediate question, but I think that LGBT people aren't different from any other people, except that often they go unnoticed. So you may not know that they need certain things unless you actually ask them, but once you have, those things all still need to be knit together.
Yes. I want to say, first of all, my name is Marian McGill. I'm from Chicago TCA Health Center, and I enjoyed your presentation. It hit close to home for me. I'm new in health facilities, but I came from social services with an organization who embraced the LGBT. We even had transgender staff, and it was we participated in the gay parade every year in Chicago. So it was embraced by our entire staff, professionals, the community, and so I think it's very important. One of the key things that you talked about was staff training, not just the medical staff, but the entire staff, the board, to embrace it and to receive it and to really be able to provide better services, because I agree that how can you manage someone if you don't know how to service them? So I just want to say that I applaud you. Everything you stated was on point, and I really want to look at implementing some of this into the programs at our facility.
So are you part of a health center system?
Yes, I am.
Which one?
TCA Health. It's we support Argyle Gardens, one of the largest public housing developments in Chicago.
Okay.
And so I came from a background where I actually worked in a very diverse community, and so it was open and discussed it through the community. I mean, it was just it was received differently, and I know that it's an issue that is kind of hidden in the community, and they don't deal with it, and the community doesn't deal with it, and so it's something that we really need to tackle.
Great. Okay, there.
Hello, and thank you very much. I am Matilda Drake. I am from Boston. I am from Mission Hill Housing Development.
It's always a problem if someone can tell you you're just full of baloney.
My question is, do you have any services for a young youth that's struggling with their sexual identity?
Do I know?
Do you have any program for youth that is struggling with their sexual identity?
Actually, it used to be, we were talking about it just before, because David runs a program in New York called The Door, but the Sidney Borum Health Center, or JRI Health, which is still located on the Boston Common, is a center that really has focused on, well, it was really homeless youth, but a lot of them turned out to be either transgender or LGBT, and still exists. It's now become part of Fenway, although it's still located separately, and they had their own program. So they had a drop-in program, they had a health center on the Boston Common, and that program still exists. And I think we've talked with other health centers about setting up similar kinds of programs. Like I know at Beth Israel we related to DIMIC in Roxbury. So I'm surprised actually, I don't know if you were ever a part of that or not, but the Community Care Alliance that Beth Israel Deaconess ran included DIMIC and Fenway and Sidney Borum, and this was one of the issues that they talked about a lot. But Sidney Borum is still there and has a lot of resources to do this kind of thing.
Yeah, but the community that I live in, we deal mostly with the Whittier Street Health Center.
Oh, Whittier Street, sure. Yeah, so it's more related to Boston Medical Center.
Yes.
But I mean, Sidney Borum, again, I don't think patients should. What? Yeah, Bagley. Well, Bagley used to. I don't know how. It used to get a lot of funding, and I don't know how. I know they're still there. I just don't know where exactly. But Bagley was a group that dealt with a lot of runaway kids, and then a lot of schools have GLSEN programs, sort of gay, lesbian, straight educational network programs that help in the schools. But Sidney Borum would be a good place to start, and I'd be surprised if people at Whittier Street didn't have some connection there. Yeah.
Okay, first of all, I'm Ashlyn Young, and I'm with Quality of Life Health Services in Gadsden, Alabama. I'm similar to you. This is new for me. My undergraduate degree is health education, and then I have a master's in special education. So I worked in the high school setting, middle school and high school, for the most part. But like I said, we're in Alabama, which is a very rural section of the state. We're in 9 different rural counties. And this is something that we're seeing more of, in the Birmingham area, Gadsden area, Huntsville area, things like that in Alabama. However, when she talked about the clinical, the staff and the people that work in our health centers need to understand this, because we're kind of it's very, I don't want to say closed-minded, but it's very, small, back in the heart of the South, very Bible Belt. So we're, it's a big issue for a lot of our providers, a lot of our nurses, a lot of our clinical staff. So do you have any suggestions of resources or people that can come in and educate our staff and do, in-services and things like that for people?
Well, I mean, I'll just, I know it's a difficult area to work, but we actually are about to do an all-day program in Nashville for, it's actually, we're doing it with the National Coalition of Healthcare for the Homeless, which is another national cooperative agreement. But Oasis Health in Nashville basically came with exactly the same issue. They said that we need to train people from the minute someone walks into our health center until the minute someone leaves. And can you help us put together a training on, focusing on youth, homelessness, transgender issues, and LGBT issues. And so we're, doing it for them. And as long as, the group is big enough, we're happy to, help think that through with you. So feel free to get in touch with us. I mean, I'm going to do a program in New Orleans, which I know is a city, but I think they still have some of the same. It's a big, compared to where you're talking about, it's a big city, but it's still, before very long, you get into some pretty rural communities that are very parochial in terms of how they feel about these issues. So I'll be interested to see what both of those programs are like once I've done them.
Okay, so who would we get in touch with to do stuff like that? Like I said, we have 18 different medical locations within 9 different counties, so we have quite a bit of staff.
Well, probably me.
Okay.
So
you're going to be the national one that would do that for me?
Someone told me the other day I'm not supposed to always say it's me, but there's no one else to do it except me. So, but if you write us at this email address, and you write and just say, you talked with me here, we can talk on the phone about it, and we'd love to be able to do stuff. And we actually already got invited to do something in Arkansas, and I think that's not too far away from Alabama, although I'm not positive. Us Northerners, we don't have our maps straight once we go too far south. Someone else had their hand up.
Can you read the email?
What?
Can you read that email?
Can I read it? Oh, yeah, sure. It's LGBT Health Education at fenwayhealth.org. And then I also have some cards here with my email address, which they don't have my right. Everything's right except for, there are things that have changed, but the email address is correct. So, I can leave these here too. You had a question, quickly?
I'm Peter Meach. I'm at the South Bronx Health Center, and I work with Dr. Scott. 2 quick observations and a question, really.
Yeah.
We've been doing trainings at the medical school on LGBT health.
At Einstein.
Now for 16 years I've been doing it. And it's been amazing how 16 years ago, the entire time was spent trying to convince the medical students that they should even pay attention. Now everybody totally just wants to know how to do a better job. And the second observation is at our health center, the staff is always very interested in this training, and we've done it and is great buy-in. But my question is, the problem is at the institutional level, it's really hard to make changes. We can do our little bit in our own health center, but it feels like to move institutions, I'm hoping the Joint Commission new standards will help push that, but I don't know if you have what you're doing in Boston to try to make something bigger than just Fenway.
I think that actually you can. For example, I was a little bit surprised, but I kind of got asked to go to the Mayo Clinic because they had a problem, and we did grand rounds. But then since then, they've actually developed a whole group of people who are trying to figure out how they systematically change the Mayo Clinic. And to be honest, I was a little concerned about what's it going to be like talking about this in Rochester, Minnesota. But they've engaged, and I think that I've actually talked to people. Well, Bronx Lebanon actually got in touch with us the other day. But I also went and met with the group that runs the health centers for Einstein. I forget what it's called. But I think that the institution just has to learn about some of the things that aren't going right, and then they'll realize that they need to kind of create some change. And I often find that because I was surprised when the University of Arkansas called and said we need to do something about this. But increasingly, hospitals are realizing that this is both it's an important issue in terms of doing the right thing. It's also an important market for them in terms of being able to take care of people who they may already be seeing but aren't getting the kind of care they need that's going to be consistent with the quality that we have to provide in the future. So, I mean, I'd be happy to talk to you about it, but I think...
One other quick question.
Sure.
On that marketing thing, I would love to find some images of same-sex couples on a health education poster about hypertension or diabetes.
Yeah.
It's always
I
HIV
totally agree
or,
with you.
Do you know of any resources out there? I was trying to persuade our hospital they should leave that.
I don't know of resources like that, but we've actually talked about creating them, and we have a lot of images. So, I mean, you know, we should, you know, we'd love to kind of partner with you to do that.
It's not just about HIV and STD.
No, it's a very important issue. But anyway, we can talk more afterwards. So I think that's it. David's standing up.
Just a few quick...
Oh, wait. We have to have our quiz. To
the next place. Here we go.
Okay, how would you rate your knowledge of initiatives to obtain information about sexual orientation and gender identity? Now. I hope everybody's an excellent. Let's see. Oh, look at that! It's unbelievable what this session has done. Now let's see. Strategies for... This is the same question. So I'm sensitively collecting and documenting patient sexual orientation and gender identity information. Look at that, even better. Uh-oh, 8% of the people in the 8% column can come talk to me afterwards. And then, how would you rate your knowledge on ways to communicate about issues related to sexual orientation and gender identity? Actually, more people are coming to the room, too. So they're good. Okay, well, I think we actually had a very successful... What?
2 more questions.
2 more questions? Oy, oy, oy.
These ones rate you.
How would you... Uh-oh. Well, I can't look then. How would you rate the quality of instruction and the presenter's level of knowledge and expertise?
You can't tell who wrote what, so...
I know, but I might have an anxiety attack. Oh, look at that! Yay! Can I send this to my boss? Okay. And then one more. How would you rate the usefulness of the workshop program content for meeting the workshop program's stated objectives? I'm not going to go back to the objectives. Okay. Well, that's pretty good. Okay, thank you.
Okay,
Thanks for reminding me that we had 2 more questions.